So this talk is really geared towards primary care physicians. And so what I'd invite you to do is if you have any specific questions related to anything that you see, physical therapy or care of post-surgical patients or care of pre-surgical patients, or just questions. Oftentimes people will have one of these problems, either themselves or a family member. So feel free to ask any questions throughout this presentation. So just one of the struggles that we have is differentiating sometimes between whether it's a pinched nerve in the neck or if it's primary shoulder. But a brief overview of the cervical spine is some definitions. Cervical spondylosis just is a term we use, is a trash bag term to really mean arthritic changes in the spine, biomechanic changes in the spine that occur as we age. And it's an x-ray that just has a lot of different changes attributable to as we get older, our joints start to degenerate. That process of degeneration results in disc osteophyte complexes, results in bone spurs, and results in collapse of disc spaces. It's that process that all gives us those big beefy facets. The bone spur is a response to just the inflammatory changes that occur in around joints, and then in response to that, the body will actually start depositing calcium, and so that's what we refer to as an osteophyte or a bone spur. Herniated disc, it turns out that as we age, we lose some water and some flexibility of the actual disc space, and that degenerative process makes it more like a hard ground up washer. If you've ever taken a washer out of like changed a washer in a sink, and that old washer is kind of hard and firm and a bit crumbly. Our discs actually do something similar. When we're young, they're nice and pliable and fresh, and then as we age, after about the age of about 40, they start to really get degenerative. And so I guess the difference is when we're young, before the age of 40, we can herniate a disc, which is that soft jelly-filled center, and that actually herniate. But as we age, we really don't herniate discs anymore. We start to get more of the bone spurring problem. In the end, our bodies don't care why something's getting pinched. So if a nerve's getting pinched, it doesn't care if it's a herniated disc or a bone spur. We feel it the same way whether we're 25 or whether we're 65. You'll still have pain down the arm. It just might be a different process to help that. One might go away with a surgery where you just pluck out the herniated portion of the disc, which is the consistency of crab meat. The other one is a bone spur, and that usually requires either some type of drill or chisel or some type of mechanical device to remove that bone spur. And then the cases, I'll show a few cases. One is axial neck pain, which is something we struggle with surgically. Radiculopathy, which is a pinched nerve in the neck. That surgically we have good results with, 80-90% success rate. And then myelopathy is a pinched spinal cord, which we have decent results with in terms of halting the process of continued spinal cord damage from stenosis or from narrowing of the central aspect of the cervical spine. A lateral radiograft of the cervical spine, 7 vertebral bodies in the neck. The first one is a ring, it's C1. C2 is peg-like. It interdigitates or marries with the ring, and that allows for really about 50% of our axial rotation. So 45 degrees of axial rotation comes from this C1-2 relationship. Below that, all the bones are square, so C3, C4, 5, 6, and 7. What we look for on our lateral radiograph is we just want to make sure the alignment's good, which it is. And then I look for degenerative changes either along the disc spaces themselves or in the facet joints posteriorly. So this is the lateral radiograph, which we just went through, and it's married with a sagittal T2 weighted MRI. And I like the T2 weighted MRI because it's really good for showing pathology, specifically the spinal cord. So if there's any injury or damage to the spinal cord, it'll light up or be bright. So this is C2, C3, C4, C5, C6, C7. In between each one is a disc, and the discs all look nice, tall, and healthy. The central spinal canal is here with the spinal cord, which is this gray structure, this ribbon-like structure. It's surrounded by cerebral spinal fluid, a lot like sea water. And if you see fluid both in front of and back of the spinal cord, you know that at least radiographically or on the MRI, it has room. And then posteriorly, we have the spinous processes. You may notice that there's a little artifact here. It's from large blood vessels. It's called flow artifact. Turns out MRI likes things to be perfectly still. And if they're not perfectly still, like blood or constant pulsations of fluid, they'll give kind of a ghosting effect. And it's just a ghost from the MRI not being able to really magnetize that tissue. Looking at more of a pathologic case or a case where there's degenerative changes, you can see that the disc heights, we start to get some mild degenerative changes with some bulging of the discs posteriorly into the spinal canal, especially here. And then this sagittal T2 weighted MRI has a line depicted here, which is this picture here. And this axial cut T2 weighted MRI is showing the spinal cord in the middle. It's showing the disc in the front, and then it's showing the exit zones or the foramina for the nerves to actually exit. So the way we read these is right side, left side. It has to do with German engineers when they initially designed MRI back in the 70s. They envisioned the body as if it was sliced in an axial fashion from the feet to the head. So that is why the right is always reversed on these scans. So when I look at an MRI, an axial MRI, I always take my right hand and I flip it across my body and I remind myself that this is the right side. Intuitively, you would think opposite, because I think intuitively you would envision looking from the head to the feet, especially as a neurosurgeon, looking, liking the brain maybe more than other things. We'd want the head to be number one, but it's just not how it was designed. So right side showing a wide open foramina. And then you can see on the left side, things are not quite as wide open. This is probably, I would say, moderate foraminal stenosis or moderate stenosis or narrowing of the actual exit zone of that nerve. So 2, 3, 4, 5. 2, 3, 4, 5. 4, 5, the nerve that exits there is the C5 nerve root. And that nerve, we would expect to have pain. If that was pinched, we'd want to see that patient have pain on the left side with pain kind of into the neck and maybe into the shoulder. And that particular nerve, that particular location, that's a difficult for one to tease out whether that's shoulder or neck, because the distribution of that innervation of that nerve really comes to the tip of the shoulder. So that's one where I have to kind of back up a little bit and rely on other things. But this is a pictogram of a front side view looking at the nerves as they exit. And unlike the thoracic spine and below, the nerves exits above their corresponding pedicle. It has to do with there's 8 nerves in the cervical spine, but only 7 bones, with the first nerve coming out between the occiput and C1, whereas everything below that, T1 through T12, those nerves exit below, and there's T12 vertebral bodies. Lumbar spine the same, there's 5 lumbar vertebral bodies, so there's 5 lumbar nerves. So the neck is a little bit different. You just have to remember that the corresponding nerve root that contains that myotome exits above the actual vertebral body. So for example, the C6 nerve root really exits above the C6 vertebral body at the C5-6 disc interspace. This is the innervation of the arm, so these are patterns. And so one thing that's pretty quick when you're assessing a patient and they say they have arm or leg pain, ask them just to take their hand and draw where it's at. And patients oftentimes will have a very difficult time telling you or describing their pain, but if you ask them just to take their hand and point to it, I find that extremely helpful. And they'll oftentimes will draw like a C6 or C7 distribution pain. So C6 will come down the arm, bicep, lateral forearm, and then it gets into the thumb. And then C7 will be more of these 3 fingers, although that diagram doesn't show that as well. And then a C8 will be down into the pinky finger. And then T1's a pretty uncommon one to pinch, but they'll always complain of armpit pain, maybe a little bit of radiation around in their pec. And so I just ask them now in clinic just to draw it for me. So post-operatively, when you're having a pain, everybody has some discomfort post-operatively. And I don't worry too much about pain unless it goes, a pinched nerve, I should say. I don't worry about too much of a pinched nerve if it doesn't go all the way to the hand. So for shoulder versus pinched nerve in the neck, if it goes to the hand, it's probably a pinched nerve in the neck. If it stays up here, it can be one of these higher cervical roots, kind of a C4, sometimes C5 nerve, and these are the two that are hard to differentiate sometimes between if it's a primary shoulder problem or a pinched nerve in the neck. But cervical spondylosis, if we run through this real quick, this is wear and tear on joints over time. It consists of facet arthropathy, and if you recall that first x-ray that I showed you, you can see that this one just doesn't look quite as clean. So the facet complexes posteriorly, they should have a nice clean shingling effect, and it starts to look a little bit grungy. And then if you look at the disc space, it starts to look a little bit ratty. Degenerative changes here at the lower aspect of the cervical spine, which is common because each bone takes up the weight of the one above it. So the ones lower are the ones that take the most beating. So in the cervical spine, it's usually C5-6, C6-7. Not as much C7-T1 just because that's a little bit more immobile. And then in the lumbar spine, it's always L4-5 and L5-S1 are the first to degenerate over time in general. Bone spurs or osteophytes, loss of disc height, and then minimal deposition within the ligaments and disc, which causes the bone spurs or calcifications. So this is a clean picture on your left, and then more of a spondylotic spine on your right, or degenerative spine on your right, or a radiograph showing bone osteophyte complexes, and then facet arthropathy. The imaging, you can see a pretty clean MRI on your right. I say that because the spinal cord has a nice contour to it as it traverses or runs from the head to the feet with good cerebral spinal fluid space. And then in this particular instance, you can just trace out the spinal cord, and you can see that it gets a little pinched here, or quite a bit moderately stenotic or moderately centrally narrowed at this level, 2, 3, 4, 5, 6. So at 5, 6, there's some degenerative changes of the disc itself. And then the posterior longitudinal ligament also is degenerative too, and it's narrowing that spine. And so in this particular patient, we would want to look for long tract signs, or those signs, those pathologic reflexes that come back, that disappear in around the age of about 6 to 9 months, and then they come back in the setting of a pinched spinal cord. So those signs are upgoing toes, or Babinski's sign. They're clonus, so constant bouncing of the feet. If you rapidly plantar flex their foot, they'll have plantar flexion. You can grab the back of their calf, and that will actually elicit a upgoing toe in some patients. So that's another plantar flexion response. Brisk reflexes of the knees, and what's a little more because some people just have brisk reflexes, but people with brisk reflexes will oftentimes have symmetrically brisk reflexes everywhere. So if you tap on their knee and they kick you in the head, you tap on their arm and they slap you in the face, that's probably more likely to be just the way they're made, although we would be concerned about reflexes above that C5. C5 is about, C5, C6 is where bicep reflexes kick in, so it could be something pinched above that. But usually if it is, at that point they're ataxic and they're complaining of weakness of arms and legs. So just brief reflexes, if you just give them a quick tap on their arm too, you can kind of differentiate the two. So in this particular patient, we'd expect them, if they're going to have any of these myelopathic findings or these pathologic findings of reflexes, we'd expect it to be clonus, upgoing toe, and then on history, we would be looking for balance issues and either grip strength weakness or difficulty with just weakness of these feeling of fatigue. And sometimes it's pretty vague. On average, it turns out that diagnosing a pinched spinal cord in people takes about 9 months. So it's oftentimes not very, it's not real obvious when they initially present. It's obvious once you get the MRI and they come, but oftentimes it takes them a while. I like this picture because it shows kind of all the different places where things can get pinched, both pinching the spinal cord centrally as well as the foramina, pinching a nerve. So the ossified posterior or posterior longitudinal ligament. So this is the axial T2 cut. The spinal cord's in the middle, the disc is in the front. This would be the esophagus and the trachea anteriorly. This would be the skin on the back of the neck. Right side, put your hand over, right side, left side. Exiting zone for the right nerve root, and then exiting zone for the left nerve root. And this is just showing you different things that can get bigger with age or bigger with different things over the years. The disc will compress things from the front, and then there's a ligamentum flavum, or the yellow ligament. That is it's a canvas-like structure which hangs between the bones in the lamina posteriorly. It's a really cool structure because it's designed to snap, to stretch and then snap back in the same position. So as we get older though, it becomes crusty, and it'll start to buckle inward. So what we'll see on some patients, especially the elderly, if they get like a lumbar stenosis or central cervical stenosis, sometimes they'll have buckled ligamentum flavum. And so that's commonly what causes lumbar stenosis in the elderly. And it seems like more men have a problem with it than women. And so when you see these postoperative patients that had over the age of about 60, 70 that have had simple lumbar decompressions, that's really what we're doing, is we're just taking out that yellow ligament to decompress the central aspect of their spinal canal. So axial neck pain, this is a tough one for us from a surgical standpoint, a tough cure. But this is a case, a 45-year-old female. She's had neck pain for 2 years following a motor vehicle crash. It's described as mid-cervical spine pain, and really tried everything, meaning non-steroidal anti-inflammatory drugs, over-the-counter, some prescription medications like Neurontin sometimes will prescribe for chronic pain. It makes people a little dopey, so they don't like it. Then going on to physical therapy. A lot of patients do chiropractic care. I like chiropractic care because it's what my patients do, and I've just, over the years, it's what people do, and they can really help. I tell my patients if they want to see a chiropractor, go to somebody in the community that is respected. I'm not a big fan of the high velocity crack. They do have some devices that can manipulate joints. That's like a little, it looks like a dart gun, and so instead of loading the dart, they load the spring, and then it pops that little thing, and it'll actually manipulate their joints. And so I like that. I think that's safe. The big risk with the high velocity manipulation of the cervical spine is they can dissect a vert or a carotid. That's less than 1%. It doesn't happen very often, but we see it every now and then, especially if you've ever been at one of the big stroke centers. About once a year, somebody will come on with a dissected vert. Sometimes it's spontaneous, but sometimes it is associated with a high velocity crack. So that's the risk of doing that. The reality is a surgery at the end of the day carries more risk than probably a chiropractic care, if we're honest with ourselves, in terms of not relieving pain, postoperative infection. I mean, if you add them all up, our perioperative risk for all of these things to happen is really in the neighborhood of probably about 3 to 5%. Everything from UTI to neuropathic pain from a nerve. So I think the risk is lower. It just happens to be a stroke, and so it's probably a little more serious. So not a fan of the high velocity crack. However, I am a fan of chiropractic care. Yoga, we're a big fan of yoga. We've actually started a yoga program in Vancouver for our lumbar spine patients. The patients that will actually do that, they'll come in with back and neck pain. If they'll complete about 2 to 3 months, they feel better. It turns out they feel a little worse up front, and so that's kind of the barrier that our patients have to get over with yoga. But if the low back pain, especially patients, will get through 2 months, they all tell you they usually will feel quite a bit better. It's just about strengthening their abdominal core. So we're a big fan of yoga. Acupuncture, turns out, works for things for about 2 days. Totally works for about 2 days. And then things tend to come back. So long term, I haven't seen anybody cured really with acupuncture, although I've seen a lot of patients helped short term. So on physical exam, this particular patient just had paraspinous tenderness. And then the surgical things that I really look for, because I can help arm pain. You have arm pain that goes to your hand, there's a surgery for you. If you just have neck pain, probably not a surgery for you. So non-focal exam means that I didn't find anything in terms of weakness, an absent reflex, a brisk reflex, or sensory changes consistent with those patterns of nerve innervations that we saw previously. And then finally on imaging, what we're looking for on the x-rays, we're looking for with the AP and lateral, we're looking for those degenerative changes, those big bone spurs. But the Flex X is nice because it'll actually show you if their spine is moving abnormally. And so what we're looking for is the vertebral bodies to really snake on one another, but not slide or translate back and forth on one another. And that's called anterior listhesis or retrolisthesis. Turns out we can have a few millimeters of both of those things, and we'll call it physiologic. But it shouldn't be profound, meaning a couple more millimeters. So we look for that on the x-rays. And then the MRI, oftentimes, as we age, we'll oftentimes just say age-appropriate changes. So axial neck pain, pain in neck and upper trapezius pain without radicular symptoms, so no pain down the arm.
What's DFN?
What's that?
What's DFN?
Definition. Short change. Yeah, it doesn't always fit, you know. It usually has mechanical components, so people will often say if I turn my head a certain way, 2/3 of us in this room will have some component of neck pain, whether it's you wake up with a crick in your neck or a sore for maybe from, and it's always either one of two things. It seems like if it's an activity, it's usually moving furniture or it's yard work. It seems like that gives people pain. I think it's just because we don't do those two things very often, and so I think that's probably why. But I don't get too worried if it starts after that. And then imaging studies, it turns out, don't correlate with how people feel. What that means is about 2/3 of the time you get an MRI on a patient that doesn't hurt at all, and it'll show you things that should maybe hurt. And the contrary is true. You'll get an MRI on somebody and nothing looks bad. So at least from a surgical standpoint, to be successful, we have to match up what looks bad on MRI with what you're telling me with what the physical exam shows. If those three things line up, we stand a good chance at helping with a surgery. If they don't, then we really don't have as good of a chance, and we need to do maybe something else to kind of tease out, at least from a surgical standpoint, of something else. And that something else is a nerve conduction test, an electrodiagnostic test, maybe some advanced imaging for low back. Sometimes I'll use a CT SPECT scan, which is a nuclear medicine scan, where you give a radioactive phosphate group and look for arthritis. So I'll use that sometimes, or some kind of dynamic study, a dynamic CT or dynamic MRI. But you know, the problem is where's the pain generator coming for axial neck pain? And I think this is why surgery doesn't work very well. Because the nerve endings actually that innervate, that people feel for axial neck pain, are in and around the disc space. They're in the periosteum of the bone, has a lot of nerve endings. They're in the joints posteriorly, they're in the facet complexes, and then finally in the muscles. So I think, at least from a surgical standpoint, I only have 3 surgeries that I can do, and 2 of them are from the front, and 1 of them is from the back. From the back, we can do a decompression of nerve roots and spinal cord, and from the front, we can do an anterior cervical discectomy and fusion, or a lot bigger decompression and fusion, or the disc replacement. And it turns out that the surgeries work really well at unpinching a nerve, but they probably don't work as well for facet pain, and they don't work probably as well for paraspinous pain, especially the posterior cervical surgeries, because you notice those patients hurt. The incisions in the back of the neck, they hurt. They're some of the more painful incisions that we do. Incisions from the front of the neck, they don't hurt too bad. Those patients might have some pain in the neck between the shoulder blades, which is really common. We think that pain between the shoulder blades after ACDF is from making them a little taller. And so when we make them a little taller, we think we put these joints on stretch. And so by putting in that graft, you make them a little taller, you put those joints on stretch, and they feel it right between their shoulder blades. So post-operatively, those ACDF patients will oftentimes complain of upper trapezius pain, and then they'll complain of a knot between their shoulder blades, and I've heard everything from a tennis ball between my shoulder blades to it just feels like a fist. That pain goes away, it takes 2 months. And it doesn't seem like it gets better gradually. It seems like they wake up one day and it's just a lot better. It probably has something to do with you make them a little bit taller, and it takes probably about a month or 2 for that graft to settle about 1 or 2 millimeters. So we tend to oversize the graft because we know it's going to settle, but when we do oversize it, it probably puts those facet complex joints on stretch a little bit, and it does give them discomfort. But in this case of an axial neck pain, you know, where's the pain coming from? And these are just different asterisks showing you where the nerve endings are. So nerve endings in the disc space, nerve endings in the joint, and the bottom line is that in general, if you can get them moving, that tends to do better. If they can't get moving right away, things like acupuncture and the steroid injections I found tend to work better. If they work well and they come back, the ablative procedures where the interventional doctors will go in and they'll deaden this nerve that runs the facet complex. That's called a facet ablation. It works fairly well for about a year, and then that nerve tends to recover and come back, and then things can get a little problematic after that. I've noticed that I've had better luck with patients with going that route than any type of surgery that I've done over the years. So axial neck pain, the imaging indications, so people that come to us, when do we actually get pictures? If there's any history of trauma, This one oftentimes get overlooked, but I think any cancer patient that has back pain or neck pain for any length of time, more than a few weeks, probably deserves at least some imaging. Probably x-rays up front are fine. If it turns out that you have to lose between 40 and 60% of your bone before you actually see it on x-ray. So it's not the most sensitive test, but it's a good place to start. And then if things don't go on, if things continue to go on, then they really need an MRI. And so this is an example of a breast cancer patient that I've had, and she had about roughly 6 months of neck pain. And a lot of people have neck pain, but she had this history of breast cancer, and ultimately she had an MRI that showed that she had some lytic lesions in her vertebral bodies, and she ended up with this surgery. And her neck pain, actually, believe it or not, even with all that hardware in there, was quite a bit better. She had stiff neck. But she's very appreciative, and she did extremely well from a surgical standpoint. But that's why the history of breast cancer, it's important to probably just jump to the advanced imaging a little sooner than you would with maybe another patient. Progressive neck pain we always worry about, and then anybody that's had neck pain for about 2 months probably needs an MRI. What we're looking for is we're looking for fracture instability and lytic and blastic lesions on x-ray. The last two, though, are problematic from the standpoint that it's not necessarily the most sensitive test in terms of getting an x-ray. This particular one was because you could see that these two vertebral bodies are clearly different, where the ones above that, 3, 4, 5, are square, peg, and then this one has almost a burst fracture appearance to it compared to the other MRI, and the MRI is to rule out the tumor or the spinal cord compression. So if you wanted to look at a really good series of articles, Consumer Reports puts out back and neck pain articles about every 2 years, and I've referred to it. It turns out that they kind of are reporting what we all kind of know, which is surgery isn't the best way to go for neck pain. The problem is that patients want an immediate fix, and so it's oftentimes harder for us to talk them out of having any surgery than it is to talk them into doing something that can to help them in terms of changing their lifestyle, diet, exercise, weight loss, going to physical therapy, working on strengthening their abdominal core or their cervical spine musculature. But what they're recommending in these articles is all the things that we really know: exercise, strengthening, over the counters. The cognitive specialist actually weighed out highly in these articles. Then sleeping on the right back or side, and then change a pillow. They were recommending. I didn't pick up what kind of pillow they recommended. I didn't pick up what kind of a bed they recommended. But anecdotally, at least for patients with back pain, for neck pain, I haven't heard anybody swear by a particular pillow. Maybe you guys have. I have had a few back patients swear by Tempur-Pedic beds. With that said, I've had a lot of patients buy Tempur-Pedic beds and not care for them, but the ones that like their beds, they always seem to be Tempur-Pedics. I don't know if that's a marketing thing. I don't know if Tempur-Pedic markets better than other beds. You know what I'm saying? But I would say consistently, if a bed's going to help, the Tempur-Pedics work, and I'm not sure what that means. Is that truly the bed, or is it just because they're marketing and more people are buying them? I'm not sure. With limited success, at least from the articles, and this is what we know, is that the steroid shots work for about 3 months. I think the steroid shots are great if people are committed to feeling better with the shot and then really hitting something, and they have to do something different. And I like physical therapy to start because you give them the exercises to do. The problem is they don't go home and do them. And then they'll start feeling better, and then they stop doing them. But if they do those, it works pretty well. And then surgery for neck pain, that's a tough egg for us to crack. I start thinking about surgery if they've failed everything else, and I can see a degenerative disc, maybe 1 or 2, and maybe they've had a little bit of success with an injection that worked for a little bit. And then at that point, I'll tell them, our experience with surgery for axial neck pain, the studies will say a 20 to 45% of patients will get better, complete, and then partial pain relief up to 50% of the time, and then unfortunately no relief in there. So what I say, neck pain goes away about 50% of the time after a cervical spine surgery. So overall, surgery 50-50, this is what I tell people. At best, no good exam, no good imaging. There's no way for me to kind of figure out you're going to do well with the surgery for cervical, for axial neck pain, and you're not going to. And then that fancy radioactive phosphate group. So we give you radioactive phosphate in your arm, circulates around, we put you under a Geiger counter, and we figure out where it goes, and then we marry that Geiger counter picture, which is this bright, kind of really neat, it's easy to read, it just lights up like a light bulb is where the radioactivity is, and then we marry that with a CT scan, and so you can see, at least from a physiologic part, match up where the calcium phosphate's turning over with an imaging study. And I've used that. It turns out that study, if the whole thing lights up, I can't help. There's not much I can do. I try to get those people to, say, a rheumatologist and maybe getting on a little bit more aggressive arthritic stance. If one thing lights up, though, we've done better with those patients. At least we feel like we have something to target and hit with a needle or with a surgery. So this particular patient, we considered this, and here's that fancy study that I just talked about. It lights up. And it can help focus our treatments of high uptake. And that's what I use it for. I don't get it very often. I probably order one every 6 weeks, probably maybe 2 every 3 months or so. I don't order very many of them. But I find it kind of helpful in these cases where, patients are just at their end of the road. They've seen everybody. They've done everything. And we're just trying to figure out something to hit. So I didn't offer this particular patient surgery because the spec was normal. And then I try to encourage this kind of thing. I think the toughest part of medicine sometimes is knowing when to say no, because we want to help. We want to help, and people are in pain, and it's trying to help them, and trying to be respectful at the same time, if not putting them through something that's going to not help. So conclusion: rule out fracture, instability, tumor. No good surgical options if those are all negative. In general, it's non-surgical, and in my practice, I've learned to say, sorry, surgery won't help quite a bit. In those patients that have little secondary gain, I'm sometimes willing to offer a surgery, and this is one particular patient that did pretty good in this long segment fusion. Now, I waited on him, though, until he developed arm pain, and then I jumped on his arm pain, but his neck pain did get better. So that's usually what I wait for, is I wait until they pinch a nerve that goes down the arm, and then kind of hop on and try to help their neck pain at the same time. And, I've had maybe okay results with that. It's still about half of them hurt. What's that?
What was that other one that went into that?
Oh yeah. Fracture. So that was probably a C2 fracture. And so if you look here, can you kind of make out that there's a lucency across there? So the reason to go with the odontoid screw anteriorly, if that's a fresh fracture, you can put a screw from the front and bring that fracture in, and it'll heal up. But a lot of times the people will have either like a congenital osteodontoidia, meaning congenitally they just never had that distal tip or very high tip of the odontoid fused with the rest of the vertebral body, or their fractures just kind of be missed along the ears, and I've had a few of those. And so then what you do is you marry C2, and then if you can safely get a screw into C1, you do, or you marry it to the occiput. I don't recall why I did the occiput. Usually I do the occiput if the arch of C1 is fractured as well. Which it might be because this distance, the atlantodental interval, or the interval between the anterior arch of C1 and the peg of C2, or the odontoid of C2, that distance is a little more than you're used to seeing on a scan.
Will they have to wear like a brace or anything, like with that, or?
So I'll put them in a cervical collar, and most of that is just to try to keep the bone fusion mass, because you need them to fuse all this together over time, and so I do put them in a collar. The reality is those screws are pretty solid, and they usually are not moving. The caveat to that is that over the age of about 70, we get pretty soft bone, and so you put these screws in and they just don't bite, if that makes sense. Can you click me back on? Oop, I got it.
Yeah, it's okay.
I have the power. So a collar, I'll do an osteoporotic bone. So you put the screw in, it just is like, if you've ever put a screw into kind of a soft piece of wood and it just doesn't bite. Yeah, so I'll put patients like that in a cervical collar too. Redict, we can help with the surgery with this. However, most of it can get better on its own. So the trick is to drag your feet long enough to see if they're going to get better on their own. And I like to go about 6 to 12 weeks to try to get people to try some conservative things before they jump to a surgery. But this is a 45-year-old male, neck and right arm pain for 6 weeks. And that pain is the deltoid to bicep, so C6, that's what that description is. And they'll draw out a C6 pattern. And then we're looking for bicep weakness, which we had, and then we have diminished light touch to the thumb, in the thumb. And here's the scan. So sagittal weighted T2 MRI, 2, 3, 4, 5, 6. 5, 6 has a degenerative disc. And then if we look on the axial cut, if we were to draw a line across this way, it would represent this. We put our hand on this side, which is the right. We have the cervical spinal cord, and we can see that this disc is out into the foramina on the right side. You can see there's a nice amount of space for the left-sided nerve to exit at C6, but on the right it's compressed. So the symptoms are dermatomal distribution from compressed nerve root, and so that was the example that we used for C6. The diagnosis I love to ask patients to just self-diagram their own pain because it just gets too confusing to try to listen to them after a while because it's hard to describe. And then motor weakness for C5, we're looking at deltoid weakness. C6, we're looking at bicep weakness, and then C7 at triceps weakness. There's cross-innervation of these two. So 6 and 5 will get these, but it turns out the deltoid's only innervated by 5. So if you ever have a patient that's weak postoperatively at the deltoid, it'll be out. It'll be really profoundly weak, and the reason for that, if the C5 nerve gets affected at time of surgery, it'll give them profound deltoid weakness. It turns out that happens about 5% of the time. We're not exactly sure why, but if you do a 5-6 or C4-5 or C5-6 discectomy, sometimes people will get deltoid weakness. That's pretty profound. The incidence of that is about 5%, 2 to 5%, and it usually gets better. It probably has something to do with the takeoff of the C5 nerve. It takes off a little bit more horizontally, and instead of 6 and 7, rapidly go to the arm, and so they're a blank angle, and 5 kind of comes out, and then so we think maybe the orientation of the nerve as it exits. I don't know if anybody really knows. The bottom line is that an anterior cervical discectomy fusion carries a risk for deltoid weakness. We don't see it in the other muscle groups as much because they're cross-innervated. So profound deltoid weakness probably will get better. We oftentimes will get patients on a little bit of steroid, and then usually get an emergent MRI to make sure that we didn't leave anything behind or compress a nerve or blood clot. And then I like this because it gives you the dermatome and the myotome, and the one that's the toughest for us is the C5, the C4 and the C5 in terms of knowing if it's shoulder or if it's pinched nerve in the neck. So to differentiate those two, I grab the shoulder, and so if you palpate the shoulder and the shoulder hurts along the shoulder capsule, along the cuff, along the rotator cuff, that's usually the shoulder. So bicipital groove is often a common place for people to be tender. And then if you ask them to point to their pain, they're usually pointing to their shoulder, and they won't draw it anywhere, or they'll draw it just to their deltoid. That's not uncommon for a shoulder to radiate to the deltoid. But a shoulder usually doesn't rotate, it doesn't radiate below the elbow. So I ask them to point, and then I grab their shoulder, and if they flinch, it's probably their shoulder. And then if you do the apprehension test where you just raise their arm, they hate it. They won't let you go back any farther, and they'll start guarding. And so that's one good other test that you can do is the apprehension test.
And
yeah.
If it was neck, that would probably open the facet and feel good, right?
Sometimes. Oftentimes you can get them to kind of bend their head to the side and open that. That's the greatest diameter or the greatest increase in foraminal. But I've had patients where that is better. So this makes sense to me. I'm not sure why this makes sense to me, unless it's somehow putting that disc in a spot, it just doesn't like, it just feels better. So I grab their shoulder. If their shoulder hurts, I say it's probably your shoulder. And I usually try to get them to an orthopedist to take a look at. But sometimes it boils down to, the same process that goes on in your shoulder or goes on in your neck. And so you can have both, it turns out. And then about probably once every 18 months, I run into a problem where it's just who goes first. It's like, do you get your shoulder scoped first, or do we go for ACDF and try to relieve a pinched nerve at C4-5? And that happens every 18 months, it seems like. So this is the rotator cuff. That's why I like this particular outline of the different physical exam and things. So what to do, non-surgical is always the mainstay. It turns out that the mantra for everything, low back, neck, is always going to be over-the-counters, Neurontin Lyrica, which works really well for neuropathic type pain. The people don't like Neurontin, as you know, because it tends to make them a little dumb. So they'll always come back to clinic and they say, I had to stop that medicine because I don't like the way it makes me think. And then I say, well, what does that mean? And then that answer is different. It's everything from kind of these visual hallucinations, which they know are not real, to this mental slowing, which they hate. So they stop it. It happens about 30% of the time. In that case, you can switch them to Lyrica, but insurance companies don't cover Lyrica up front because it's expensive. Physical therapy is a mainstay of initial treatment. Cervical traction. Do you all do cervical traction? I've had some people do the little puff-up devices. I've had some people throw a pillow or throw the water bag over the door, or the head of the bed. Some people swear. I've had some patients swear. Of those patients who try it, probably about half of them like it. But the overall goal is to strengthen, stretch. Correct? Awesome. I'm telling them the same thing. Steroid injections, I like them because they get people out of pain, and then if they get moving, I think it's better. If they use it and they don't do anything different and it comes back, I think that they have to do something different ultimately. But I do like the steroid shots. There's not a lot of side effects to them. If they're diabetic, it throws their sugars out of whack for about 3 to 5 days. We know that repeated steroid injections in the same spot is bad. We know this because the weightlifters back in the 70s, 80s, 90s used to shoot their shoulders up so they could continue to lift. And what they found is they were just kind of eating away their joint capsules or bone over time with repeated steroid use. But you have to do quite a bit. In general, it's safe to get a series of 3 shots in the same spot in 1 year. So if they come with a neck problem and they get an injection, they're better. They can safely get a hip injection, a knee injection, a shoulder injection. And we see that. Chiropractic care, I like it. I just don't advise the high velocity manipulation because of that very small risk of carotid or vertebral artery dissection. Acupuncture, I have a lot of patients do it. I like it if they use it in context of trying to do something to get better. So they're working hard in physical therapy, they're working hard in yoga or whatever they're doing to try to be physically active. And because of that, they're sore, and I like it to help them get over their soreness, help them to feel better while they're trying to get better. I haven't found it particularly helpful if they're not willing to do that thing, just because it's so doggone it's expensive after a while because you have to go a couple times a week to get over an acute thing. I do have plenty of patients that go every couple weeks to every maybe once a month, and I think that's probably okay in terms of not being so much money out of pocket. But I think most insurance companies, if they do cover acupuncture, it's about 6 to 12 visits a year, and you can quickly run through that. And then after that, it's usually in the neighborhood of $40 to $60 is what I've asked my patients. I don't know if any of you have ever had that experience too, but it does work. It just is self-limited. So surgery, I reserve for upfront life-limiting pain. So if somebody comes in and they're just in a lot of rip-roaring, radicular pain, and they can't go to work, and they're holding their head up, or it's leaned across their shoulder, and they're just miserable, I'll offer those patients a discectomy up front. Anything longer than 2 months that really hasn't gotten better, it usually doesn't get better after that, is my experience. And that's the studies will show out if things don't get better up front. So what I like to see at that follow-up visit in around 6 to 8 weeks is I like to, I'm still hurting, but I'm not trying to cut off my arm anymore. And so those patients I'll continue to follow. Or if there are motor weaknesses, if they have a deficit, either tricep, Big one is tricep or bicep. If that's weak and it's getting worse, then at that point I'll offer them surgery. If it's a little weak coming in though, I'll sit on that because I've had plenty of patients. The motor, as long as it's not out, it'll get better. And then surgery, we have some choices here. And I tend to go do the fusion now for patients with degenerative changes because I'm afraid that if we take out a bone spur, that'll come back if it continues to move. And I tend to do the disc replacement for a herniated disc in younger patients. The reason to do the reason that this device was invented was try to prevent the adjacent level disc disease that occurs about 2% per year. So in around a decade, 20% of people that have this will go on and have another problem at a different level. So to try to prevent that, we invented this. We've been doing this now for about three decades, and that study hasn't come out showing that it's decreased the incidence of adjacent level disc disease. So probably, I'm not sure it does. It's probably a combination of the way we're made. The people that get this have a problem with just the way they've degenerated their joints over the years, and they're more likely to get an adjacent level disc disease. But I do like the idea of biomechanically preserving motion long term, especially in younger patients. So this particular full strength, diminish light touch on the right in its C6 distribution, so offered surgery. And so this was big for primary care during that conference, just to kind of showing you the type of hoops that we have to jump through when we try to get a surgery authorized. This is Molina. So this was Molina. They use this particular evidence-based clinical criteria or surgery algorithm. And so this is an example of their algorithm that they subscribe to. So the first thing they ask, is they have a little checkbox, unilateral redict with sensory deficit, yes. And then they say if the number of options is 1. So this is usually somebody that, is just running through it, doesn't have really a medical background per se. And so they're just following this checklist to see if a surgery is authorized. And so they look for these things. This is where conservative measures come in. Important is oftentimes we can't get surgeries approved without conservative measures, which is appropriate. And so this particular patient was denied until we documented 6 weeks of home exercise, which is a little bit of a bummer because people are in a lot of pain, and if they come in a lot of pain, it oftentimes doesn't get better anyway. We were able to ultimately get it approved and did it. But the outcomes, 80% of patients will have arm pain relief. These are the risks of the surgeries from the front, and they're risks just based upon what we have to go around or dissect out. So 5% will have difficulty swallowing, and that's permanent. It's probably higher than that and you've seen that. People with anterior cervical septal fusions oftentimes will have a difficulty swallowing. It usually goes away, but 5% of the time it doesn't. If you do a long-term barium swallow study, a lot of patients will have motility problems after ACDF, and it's just simply from exposing the esophagus and moving it out of the way. You deinnervate that portion that you've exposed, and so it doesn't contract quite as well after it. Most patients don't have a problem with it, 5% do. The recurrent laryngeal nerve, we can stretch, and that can be damaged to 5% of the time. It's just the nature of the approach for the surgery, and that leaves them with a hoarse voice. If you've ever heard anybody with a hoarse voice afterwards, it can be either from the intubation tube or from the surgical approach. Fortunately, it usually gets better. I usually start referring people on to an ENT surgeon to scope the vocal cord and see if it works in around 2 to 3 months after a surgery if they continue complaining of a hoarse voice. Here's that deltoid paralysis or deltoid palsy. That's about 1%. And then long-term, 1 to 2% of per year, about 25% of patients in 10 years will have an adjacent level problem. And so they come back and they pinch another nerve at a different level. The anterior cervical replacement, or ACR, it turns out that you go in trying to do that, but if you have to drill off too much bone to decompress the nerve, the whole goal of the surgery is to unpinch the nerve, but that device is made to sit on the cortical bone. So if you have to whittle away too much cortical bone, you have to fuse it, because that device will just, if you remember I told you things kind of subside about 1 millimeter or 2, that device will actually just piston into the vertebral body, sink into the vertebral body. And if it fuses, which it turns out about 30% of them ultimately fuse, that's not a big deal. But what happens if they piston in, then you decrease your foraminal height, and then you pinch your nerve again. So it's kind of a heartbreaker. You did the surgery, it's sunk into it, and now you pinch your nerve again. Now we have to unpinch things from the back. And then recovery to return to work is 2 to 4 weeks. I tell patients to take off 4 weeks, plan on 4 weeks. Industry workers usually like a little physical therapy before they're back to get some confidence in terms of lifting and pushing and pulling. Desk workers usually are back in about 2 to 4 weeks. And if they can change positions frequently, they do fairly well. I'm running out of time, aren't I? Cervical redic. Just some studies showing that it works really well. 80%, at least the equivalent in this particular study. If they had neck pain before and arm pain, then the neck pain was better relieved. So that's a good reason to do it. Life-limiting pain, more than 2 months, progressive motor deficits. And then myelopathy I kind of quickly burn through, but it just basically means to pinch spinal cord. And that pinched spinal cord, as we get older, is either from ossification of the posterior longitudinal ligament or thickening of the posterior longitudinal ligament, or sometimes from buccal ligamtum flavum or degenerative disc. And those symptoms will be upgoing toes, Hoffman signs, which is you flick the finger and the thumb will twitch. And then if they walk, they have this characteristic spastic gait. And then you get the imaging, and they'll have an impinged spinal cord, and then sometimes they'll have some and if you stare hard enough, you can kind of make out where that spinal cord maybe has a hyper intense signal or a white signal, and that's a sign that the spinal cord has had some trauma to it. So the whole reason to do this surgery is to prevent things from getting worse, knowing that about 10% of them, you do the surgery and they get worse. So it's really a preventative surgery because we know that long-term patients will have a steady decline with time, and it's always it seems to be this stair-step fashion. And so they'll be fine for a time, and then they drop, and then they're fine for a time, and then they drop. And they'll actually get some recovery back, but they'll never be back to baseline. So it's really the surgery for cervical myelopathy or pinched spinal cord centrally is to prevent that stair-step decline over time. And so this is an example of something that we would do to unpinch the spinal cord from the front. In general, we'll do a decompression from the front if their alignment's good, if their alignment's or if their alignment's not good. If their alignment's good, like this particular, you'd have the option to go from the back, and that's where the laminoplasties come into play. Just a wide posterior decompression will come into play. And so this is a particular case example, and in this particular case I did a laminoplasty, which is you go in and you make the canal diameter larger by fracturing the lamina on both sides and then propping up the lamina on one side with these little plates and screws. And so it kind of raises the roof or tilts up the roof on one side. Short term, it seems like their balance gets better. Long term, they all seem to complain of grip weakness and mild balance and issues, and then sometimes paresthesias into their forearms, which usually gets a little better with the neuropathic medications. This is the big risk, is roughly 10% they'll be a little worse post-op. We think that's because it's pinched, and so you unpinch it and the blood flows in there, and so they get a little swelling probably from blood supply, and that usually gets better, but not always.
What's the timeline for that?
Right away, it seems like. I quote 10%. I can't say that I actually see that. But that's kind of what the studies I've read have shown. So that's what I quote people. They're usually transiently right up front. They just are weaker, globally weaker, and then you get an MRI and you get things to make sure they don't have a clot, and you'll see maybe a little bit more swelling in the spinal cord. And we think it's either from somehow unpinching it makes things transiently worse. They tend to get a little better. But not always. The goal is to prevent their step decline over time, though, and it works well for that. That's it, actually. This is our conference that we sponsor in March. This year it's for primary care, but this year we also have an athletic trainer component. If any of you physical therapists are athletic trainers too, you can contact me for info or look on our website for info. So this year we're going to have our athletic trainers serve a lot of the sports teams around town. And so I'm not exactly sure their topics, but I think their topics are going to be sideline assessment of the concussed athlete, sideline assessment of the knee, sideline assessment of the ankle and the shoulder, I think is what they're going to focus on this year. And that's going to run in parallel with the main conference, and the main conference is case topics in orthopedic and neurosurgery. We're covering osteoporotic fractures of hip and femur, both medical and surgical management, and then neurosurgical emergencies, and then a few kind of gee whiz topics that primary care verbalize if they're interested in coiling of aneurysms, kyphoplasty for osteoporotic compression fractures of the thoracic and lumbar spine. So, any questions?
I have a question about patients that get like cervical fusions. So they're so terrified to move at all. What can we tell them like that they're allowed to? Like what range of motion? Because they like literally will sit there like this.
Yeah.
And then like,
I've seen it.
Yeah, so you have to like stand at the foot of the bed to be like, hey, like. So what can you tell them?
So I think I knew you were going to ask that. So I think for fracture is a little different than for herniated disc or degenerative. I think for fracture, I think they just will put them in a collar and they probably just shouldn't move their head.
Okay.
For degenerative, for ACDF, I mean, those screws are solid, things are solid. Patients do better if they start to move things every hour a little bit. So every hour, if they can just gently move their head. Their neck does tend to loosen up quicker than if they don't do that. That's really tough for anxious patients to say up front. And then on top of that, half of us seem to use cervical collars, and half of us don't. And so I tend to use a collar if it's osteoporotic bone or in the anxious patient because they tend to want it. So I guess I wouldn't worry about it too much up front, other than to just reassure them that it's okay to move their neck within reason.
Turn, but like,
they shouldn't force it, I think.
No, but like they can like look at you.
Yeah.
So
But they can technically move it with respect. Meaning don't force it. I used to say you could force it, but I did have one patient who was a neck popper, and he did knock his screws loose. But that's what it took to knock a screw loose. It took this guy doing this all the time, and finally he loosened up some screws, and so we had to do something. But that's what it took. So just this, really those screws are pretty solid.
I just want to make sure I'm not lying to them.
No, you're not lying to them. They can move their neck. And the other thing is I think we can't win sometimes, and people are going to kind of do what they're going to do. Just reassure them that that's okay and that their screws are solid.
So in patients that you don't want a collar, they don't need the collar. Is it always okay that we try a soft collar just for comfort or support?
For me, it's okay.
Okay.
Yeah, and I can speak for my colleagues
Are
that
they all okay with that, or do
my colleagues would be okay with that. Yeah,
Okay.
yeah. They might grumble a little bit, but in the end, they're not going to bust
If they
anybody's
do, I'll
chops
direct
for it.
them at you.
What's that?
I said if they do, I'll direct them at you.
Yeah, well,
You tell them to talk to me. Tell them I said it to them. You can do that. Yeah, you can do that. If anybody were to yelp at you from our side of the fence, you just tell them I said it was okay, and that they should talk to me. And they won't. They'll probably laugh. Or say this, that's not what Dr. Ragel does. Well, that's not what Dr. Ragel does. So tell them that.
I'm sure that
Dr. Ragel?
Yeah.
What if it's not a fusion? If it's just a laminotomy discectomy? Are there any
Those-
range of motion precautions?
No, there's not, but they really hurt. I mean, those posterior cervical incisions, because this is such a big muscle, so it's other than the heart, it's like the most used muscle in our body, because as soon as you wake up, you're holding this 10-pound head up, and this 10-pound head is the way we interact with our environment. I mean, you hear something, you turn your head. You see something, you turn your head. So our neck muscles are always firing. You can't baby them. Even in a collar, it's tough to baby them.
But if it's not fused, there's no way you can do damage by movement, right?
No.
Okay.
No, I mean, I guess we should never say never, but I guess if you were doing this, maybe. So the risk of a posterior laminotomy is that we know that in most patients, we can safely take about a third of that facet capsule and through that. and we get away with it most of the time. Every now and then somebody will have some instability, and that takes a couple months to kind of tease out usually because they're all in pain up front. Yeah, you stick a retractor through that muscle and it hurts.
What about lumbar laminotomy discectomy? Is it really important that they move carefully and log roll to get out of bed, or is movement okay?
You know, it is important to do those things, mostly because if they spasm that muscle, it sets them back, not because anything's going to fall apart.
Okay.
It's more about trying to have them smoothly transition into better motion without spasming or tricking something where they don't move at all, because then that's when these, that's just a harder thing to overcome once they get kind of this cycle of myofascial pain or myofascial syndrome or whatever you want to call this cycle where muscles lock up and they move and it locks up and they move. So it's nice if they can kind of gradually do that. That's why I think where the log rolling and the things that physical therapy does such a good job of teaching them, you know.
Okay.
So.
Is there any, like, you know, the patients that you don't put a collar on and they want one because they're anxious, is there any, like, I mean, they obviously come in for their follow-ups with you guys, you know, where some of them put the collar on and they leave it on all the time and they don't move at all, and where they should be doing a little bit. Is it ever a problem where they?
No, it's not. I think, you know, after I've had patients come in with collars. I've never had patients come back at I kind of see them at 2-ish months, you know, a month and a half to 2.5 months. And sometimes they'll be in collar then, but they never come back at 6 months to a year with a collar on. So they've learned to get rid of it, with rare exception. With rare exception.
There's always rare exceptions.
Yeah. No. Yeah. Yeah. Yes.
I have a question about, you mentioned yoga.
Yeah, we love it.
Is that in-house, or do you just have people pick out their own yoga classes?
So we deal with you know, high BMIs of 30 and 40. We all do. So those patients have a very difficult time with yoga to start. We have a program where it's a very small class of about 8 to 10 people, and it's really a one-on-one with an instructor that really loves, you know, getting people through injury or chronic problem. And so they get a lot of one-on-one, and it's mostly focused on, we call it yoga light. You know, it doesn't have the spiritual aspect to it as much as it's just moving your body with some simple poses without doing the pretzel stuff.
And so the instructors are knowledgeable about.
Yes. Yeah. So it's so the way that works is we'll refer them to one of our physical therapists that runs that program. They do he does a general assessment to see if they're going to actually be able to do it, because some people just can't. But they have to do a few simple things with him, and then he'll get them into that program. And then I think it's about $10 a class. And the hope is that they graduate from that and get onto like a regular yoga program. And so we know that, so this all started because Andy Nemechek, who does some of our scoliosis work, Dr. Nem, he had a patient come in that had just this wicked curve. And he offered her like a T10 to the pelvis fusion. And she said, hell no, no way. I'm not doing it. I'm doing yoga. And he said, all right, you know, whatever. She came back in a year and she was not perfect, but she was a lot better. And her spine actually was straighter on x-ray. So because of that patient, Andy started the program. And so what we've seen is that the patients who will do it do pretty good and they like it. And then from just a chronic low back pain standpoint, what we've seen is that if patients they have to be committed. So if they're willing to do it, it sucks for about 2 weeks. And then they hit this plateau phase for about 2 months. And not a lot changes. But at that 2 months, a lot of them will say, my back hasn't felt this good in years, you know, hasn't felt like this in years. And it beats the heck out of that hardware we put in, honestly. So we like it, yeah. The problem is a lot of people, it's hard, you know, it's just hard to do something for 2-3 months.
It takes consistency.
It takes consistency. But if they'll buy into it, it'll work. You know, I haven't seen an exception to that one yet, to the collar thing, yeah. Yes, I'm sorry.
For your patients, that you do order the hard collar, do they leave the surgery suite with the collar on? Or-
Oftentimes, no. I mean, because that collar comes up from below, and half the time nobody knows where it's at. So it's okay to put it on the ward.
Because the thing we've run into, not necessarily with these patients, but some patients that their neurosurgeon will say, well, get a collar, and a manual has a ton of different sizes. Our MSO orders like two
Yeah.
sizes, and they'll be too tall.
Too tall or
or
too short.
Too short, or not wide enough. So that's the only thing we run into problems with sometimes.
I it's not like their head's going to fall off if they don't have it on. I like it in the anxious patient, and I like it in the osteoporotic bone. Those screws are not going to pull out in the short term. They're going to pull out in the long term. And that long term is going to be somebody popping their neck is what I've seen. The osteoporotic bone, in reality, I can't say that I've seen hardware failure. They just don't fuse.
So the ones that you want, you're going to be really clear in your orders.
We order collar, but honestly, whether it gets put on then or in a day, I don't
It's
tend to
okay.
mind.
Great.
Yeah. Most patients aren't trying to crack their necks right away anyway. I mean, they're pretty cautious. Yeah.
Thank you.
You guys do lumbar fusions too, right?
Oh yeah.
Sorry, my brain's a little dead. But
Right.
when they
Yoga first though, right?
Huh? Yoga first, yeah. But with the like lumbar fusions that don't come up with their brace,
Yeah.
are we not supposed to get them out of bed until they have their brace? Because that's what we've been doing for the whole time I've been there. Like, can they get up and go to the bathroom, or are we supposed to do a bedpan until?
So I'll speak for rebound.
Okay.
Get them out of bed. Yeah.
Okay.
Get them out of bed. Yeah, go ahead.
How far can they go? Like bedside commode?
Yeah.
Or- Okay,
Yeah.
good to know.
Yeah. That LSO, that's a lot of patient confidence, and so some patients just really like it on. It gives them a lot of lumbar support, which I think really helps some patients. Half of them like it, half of them don't. I like it in the cautious patient, like the anxious patient, or the patient. Some of them aren't anxious; they just feel better with it on. And then the other one is the patient that's doing really well. I like it because they don't go move furniture or do yard work with the back brace on, which is the two most common things to hurt yourself. It seems like that. I don't know.
Any last questions? I hate to
Yeah.
cut you
Yeah,
off,
yeah.
but we have two
Nope.
other students that have to leave at a certain time.
Thanks for having me.
Thank you.